Hi everyone, I'm going to talk about last topic of the day, which is perioperative one lung ventilation. So one lung ventilation actually refers to a separation of the two lungs in which we ventilate one lung while we allow another lung to be deflated. So this technique is a standard approach to facilitate surgical exposure, but it also can be used in the ICU patient in which we want to isolate a healthy lung from a pathologic lung. If we look at the absolute indication, most of it falls under ICU patient. So we can use this to actually prevent damage or contamination of the healthy lung. In which we isolate the unilateral lung abscess or unilateral pulmonary hemorrhage. We can also use one lung ventilation to control distribution of ventilation, in which we isolate the lung with the bronchoporous fistula to allow healing. So we also can use to facilitate single lung lavage, such as cases like cystic fibrosis or alveolar proteinosis. So most of the surgical indication are actually relative. So it can be used to facilitate surgical exposure in cases like pneumonectomy, lung volume reduction surgery, and recently commonly practiced minimally invasive cardiac surgery, lobectomy reps surgery, and in the upper GI surgery like esophageal surgery and also mediastinal mass reduction. So most of the contraindications are actually relative. So it is relatively contraindicated in patients who require two lungs to actually ventilate and oxygenate, like in a patient with a high ventilator setting or severe pulmonary disease, or patient with a limited lung reserve due to prior pulmonary resection. So in these kind of cases, we can actually consider selective lobar blockade with a bronchial blocker. So assessment and management of the patient can be divided into pre-op, intra-op, as well as post-operative. So pre-operative, same goes with all the patient. You have to take a full history, perform a thorough physical examination. You have to focus more on the cardiopulmonary function status, evaluate the functional status, and any presence of a cardiac or pulmonary disease. Not have to rule out any active respiratory infection in which we have to treat and allow for recovery for at least 2 weeks. Airway assessment is paramount. We have to look for any feature of difficult airway or any airway mass, airway obstruction. We also have to assess for most comfortable position for the patient because let's say intraoperative or after induction of general anesthesia, if the patient is saturating, so we have to quickly turn the patient back to his or her normal, most comfortable position. Okay, evaluate the oxygenation. So lung function test, which is important to actually predict the suitability and for the pulmonary resection. So imaging is important to delineate the mass, to look for any compression or of the airway as well as major vessel, to look for any distortion of the tracheal bronchial. So patient management has to be multidisciplinary. So traditionally, for pulmonary resection or pneumonectomy, quantitative pre-operative assessment has been thought of as a three-legged stool, which would include assessment of a respiratory mechanic, cardiopulmonary reserve, as well as the lung parenchymal function. This is a DLCO, okay? Diffusion of a carbon monoxide. Predicted post-op FEV1 actually estimate the FEV1 after lung resection. So it can be calculated through lung segment counting. So there are 10 segments on the right as well as 9 segments on the left. So in patient undergoing lung resection, this formula above can be calculated to actually come up with a predicted post-op FEV1. So NAS guideline actually suggested that the recommended limit for PPO values for FEV1 and DLCO for surgical resection is 30%. So any patient with the PPO values below 30%, they are at high risk of post-op dyspnea and requiring long-term oxygen therapy. So these patients have to be referred for formal CPAP. So CPAP testing actually is available in Queen 1 under RESPI. So it's a exercise test that require patient to be on the treadmill as or standstill bicycle, in which the patient walk alone, ventilation, SpO2 heart rate ECG, as well as the VO2 max will be monitored. So VO2 max is the maximum oxygen consumption, which is measured in the mils of oxygen per kg per minute. So in a patient who is very fit, the value will be above 20. So if the value of VO2 max is more than 15, that shows the patient has a good functional status and should be fit for the operation. And if the value is less than 10, then patient is actually at high risk of developing dyspnea and mobility post-operative will be high. So this kind of patient has to be counseled for um, other type of procedures such as maybe lobectomy instead of pneumonectomy or that kind of thing, or conservative. So during the round, we have to explain the anesthetic technique plan and explain it to the patient, take high risk consent, plan for availability of ICU backup. So analgesic option includes a multimodal analgesia such as thoracic epidural, regional block, opioid and non-opioid. Okay, we have to optimize the nebulizer and prescribe antibiotic if the patient has evidence of active infection. Okay, you have to start chest tissue early and effective spirometry pre-operative and smoking cessation as soon as possible for those smokers. Okay? Operatively, monitoring includes a standard GBI monitor, plus minus outline and CVL depending on the type of surgical procedure that we're going to do. Okay, you have to anticipate hemodynamic instability intraoperative. So there are three types of lung isolation technique that is available. Commonest will be a double lumen tube. Second one will be a bronchial blocker. Then the third one will be the use of single lumen tube intubate into the main stem bronchus. So double lumen tube is the commonest device that is being used to perform a one lung ventilation. It is available in the left or right side double lumen tube. The one that is commonly used is the left double lumen tube. So people has been using left double lumen tube as much as they can before they even consider right side double lumen tube. So why is it so? Okay, we can look at this. This is a left double lumen tube. We can see there are actually two tracheal lumen, one tracheal lumen, one bronchial lumen, two pilot cuffs. One is for bronchial, one is for tracheal, and we can see there are also two curvature. One is the endobronchial curvature and one is a tracheal curvature. So the picture on the left is showing the development left endobronchial cuff. So this picture is showing left as well as the right double lumen tube. We can see the endobronchial curvature is curving towards the side that you want to intubate. Right double lumen tube as well as left double lumen tube. Okay. So clinically, before we actually perform intubation, we have to ask which type of double lumen tube that should be used. As I mentioned earlier, the left double lumen tube is most commonly selected due to the higher margin of error. Why is it so? Because in normal adult, left main bronchus length is about 5 cm compared to right main bronchus, which is about 2.5 cm. So it is actually easier to intubate and ensure correct positioning of a left double lumen tube compared to right double lumen tube. And then there is also presence of a right upper loop with a variable takeoff from a right main bronchus. So there is a risk of actually obstructing the right upper loop if you use a right double lumen tube. So it is more challenging and prone to cause complication for a right double lumen tube. That's why most of the clinicians will go for left double lumen tube as much as possible. Although most of the surgical procedure can be managed with the left-sided double lumen tube, there are some specific indications in which clinicians should try to avoid a left double lumen tube and use the right double lumen tube instead. So this is a few indications include for right double lumen tube like surgery involving a left main bronchus, like left pneumotomy, left lung transplant, patient with a left tracheal bronchial disruption. So the disruption, it can be due to aneurysm of the descending thoracic aorta, which will actually compress and collapse the left main bronchus, tumor compressing the left main bronchus. So the picture on the left is showing a intraluminal tumor over the left main bronchus. So in this situation, we can't use the left-sided double lumen tube, obviously. So in this patient, we have to use the right double lumen tube or other device like bronchial blocking. So the picture on the left is showing external compression to a left main bronchus. You can see that the left main bronchus is actually being compressed. So in this patient, it is actually quite difficult to use the left double lumen tube. So the second question that we should ask is what size of double lumen tube that we should choose. So a common problem is the lack of objective guideline to choose properly between the appropriate size of double lumen tube. A properly sized double lumen tube is the one that can easily pass through the glottis and at once without resistance within the trachea, with the bronchial component passing into the intended bronchus without difficulty. So the most accurate method to actually select the size of the double lumen tube is to use the measurement of a left main bronchial diameter from a CT scan. But the problem is not all the patients will have a CT scan with them, and then some of them will not have a CT scan. Then a traditional approach, most of the clinician will actually use a select size depends on the patient height as well as the patient weight. But this is not actually so accurate. Okay, so this table from up to date is showing suggested size of the double lumen tube according to a patient sex as well as height. But a lot of study has actually shown that this is not so accurate. Okay? So what happen if we don't have a CT scan to actually measure the left main bronchial width? So this study is actually showing tracheal width and left bronchial width actually can correlate quite well. So they actually suggest that the tracheal width to be used as the best predictor of a left bronchial width. And then they come up with a formula to actually assist clinician to choose the size of the double lumen tube according to the tracheal width alone. Okay. But I think in a clinical practice, most of the clinician will actually choose the size of the double lumen tube according to their experience and their preference. Okay. How is a double lumen tube inserted? So first of all, we have to check the integrity of the tracheal as well as the bronchial cuff. We have to lubricate the double lumen tube first. So after induction of general anesthesia, patient is deep enough, then we perform direct laryngoscopy and visualize the glottis. Then we advance the double lumen tube until the endobronchial cuff has passed beyond the vocal cord. Then we remove the stylet. Then we rotate the double lumen tube 90-degree clockwise or anti-clockwise, depending on the site that we want to intubate. Then we pass the tracheal cuff beyond the glottis until resistance is encountered. Then we should stop. Okay. Okay. This picture is explaining. Okay. So first of all, like I explained, we have to rotate the tube 90 degree according to the side of a bronchial that we want to intubate. Okay. So after intubation, how do we confirm the positioning of a double lumen tube? So it can be done clinically as well as through fiber optic bronchoscope confirmation. So after intubation, after we think that it is already placed well, then we have to first of all inflate the tracheal cuff. Okay. Then usually the volume required is about 5 to 7 ml for tracheal cuff, followed by 1 to 2 ml for bronchial cuff. So after that, we have to secure the double lumen tube first. Then we proceed with ventilation through both lumen. So initial ventilation should result in the equal bilateral breath sound with the both cuff inflated. Okay. Then we go on and clamp the tracheal cuff. Then after that, the ventilation should result in the breath sound on the left and absence of breath sound on the right. Okay. So next, we should connect back the tracheal cuff and then we clamp the bronchial cuff. And ventilation should result in breath sound on the right. Okay. But not on the left because the left bronchial lumen is being clamped already. Okay. So we should repeat the same step for right double lumen tube, but on the opposite side. Okay. This flow chart is actually showing how do we confirm the placement of a double lumen tube clinically. Okay. So you can go through this and go through this again later. So now I'm going to talk about fiber optic bronchoscope conformation. Okay, traditionally the actually study has actually shows that 24 to 39, about 40% of a blind insertion of a left double lumen tube without fiber optic conformation will result in endobronchial intubation of a right main stem bronchus. So the misplacement of a double lumen tube is actually common if we don't confirm with the fiber optic conformation. So how do we do it? Initially, we insert the fiber optic bronchoscope through a tracheal lumen after clamping of the tracheal lumen from the ventilator. And then we should visualize the carina. Then we have to identify the blue color endobronchial cuff, okay, as a thin trace within the left main bronchus. This is for left double lumen tube. But for a right-sided double lumen tube, in addition to the above step, we have to visualize the endobronchial lumen and to ensure that the Murphy's eye is aligned with the right upper loop bronchus. Okay. You can see this is the left double lumen tube. We can see the blue color thin rim just at the just above the left main bronchus. Okay, this is a correct positioning on the right. But if you look at the picture on the left, we can't see the endobronchial cuff because it is actually too deep already. So in the left picture, we have to deflect the cuff, both tracheal and the endobronchial cuff, and actually pull out a bit until you can see a thin blue color rim just outside the left main bronchus. Okay. So the right side is the correct positioning. Left side is too deep already. Can see or not? Yeah. So as I mentioned earlier, this is the picture on the left is showing a right-sided double lumen tube. There is a Murphy's eye, which function to actually ventilate the right upper lobe. Okay. And this picture is showing intubation of with the right double lumen tube. And we can actually see that through the opening of a Murphy's eye, we can see a right upper lobe opening. Okay, so this is what we should see through a fiber optic. Then next we talk about the sizing of a fiber optic bronchoscope, because we have to remember that even though the size of the double lumen tube is actually quite big, but the internal diameter is actually quite small. So the type of the fiber optic bronchoscope has to be small. So most of the time we have to use the size 3 bronchoscope to actually confirm the positioning of a double lumen tube. Okay, this is a recommendation. Then next we talk about the physiological changes during the one lung ventilation. The initiation of one lung ventilation will stop all ventilation to one lung. So this is effectively will reduce ventilation by 50% and creating a sham. Okay, and most of the thoracic operation, patient will be in the lateral decubitus position to further facilitate surgery. So in this position, the upper lung will be termed as dependent, whereas the lower lung will be termed as non-dependent, respectively. So we talk about perfusion. The primary physiological changes that take place is the perfusion of the non-dependent lung without ventilation, because now we are on one lung, we are actually ventilating most of the time ventilating the dependent lung, and the non-dependent lung lumen will be clamped already, so there will be no ventilation to a non-dependent lung, effectively causing a large shunt. However, the shunt is actually minimized by a phenomenon called hypoxic pulmonary vasoconstriction, in which the blood flow to a hypoxic alveolar will actually reduce due to a vasoconstriction. Vasoconstriction, this HPV is triggered by alveolar hypoxia. So the moment we clamp the lung lumen, the alveolar will experience hypoxia and HPV, hypoxic pulmonary vasoconstriction, will be activated. At the same time, the gravity will actually cause decreased blood flow to a non-dependent lung. So this will actually minimize the hypoxemia. Okay. So as we can see, the effect of gravity is actually pulling the blood, and more perfusion will actually happen to a dependent lung. Whereas a non-dependent lung, which is not ventilated, will have a decrease in the perfusion as well. This will minimize the hypoxia. Okay. So the ventilation, which part of the lung will be better ventilated? And let's say we are still on lateral decubitus position with a two-lung ventilation. So it depends on whether a patient is breathing spontaneously or paralyzed. So expansion of the dependent lung is actually restricted by the weight of the mediastinum. Okay? And the convolute placement of the diaphragm and abdominal organ will push the diaphragm higher. So this will cause a reduce in the compliance of the dependent lung in the patient who are paralyzed. Okay? But let's talk about overt patient. But I think this is clinically not relevant, because most of the time patient will be anesthetized as well as paralyzed. But let's say a patient who is awake and in a lateral decubitus position, the dependent lung will be on the more favorable part of the compliance curve because of the diaphragm advantage. So in the overt patient, diaphragm is active. So the abdominal content will push the diaphragm higher during expiration, and then the diaphragm contraction during inspiration will actually cause a better ventilation in the patient who is awake in a lateral position for dependent lung. Whereas in anesthetized, paralyzed patient, the diaphragm is paralyzed and abdominal content will push the diaphragm upward. So this will reduce the ventilation and in the dependent lung. Okay, normal physiology. Okay. So this picture depicts the effect of a HPV, hypoxic pulmonary ventilation, in a patient who are on two lung versus patient who are on one lung ventilation. Okay, so you can see that picture on the left, patient who are on two lung ventilation, both are ventilated. The blood flow to the dependent lung is 60%, whereas the blood flow to a non-dependent lung is 40%. But as soon as patient goes into one lung ventilation, okay, the non-dependent lung is lumen is being clamped. There will be a reduction in the blood flow further. So the dependent lung will receive 77 or 80% of perfusion, whereas the non-dependent lung will receive about 20 to 25% of the perfusion due to the effect of alveolar hypoxia and activates HPV. So this will further reduce the pulmonary blood flow to the non-dependent lung. Okay. Okay, let's talk about the ventilation strategy. So thoracic surgery with one lung ventilation can result in a spectrum of lung injury ranging from mild to severe ARDS. So to minimize the risk, ventilation strategies adapted from a lung protective strategy in a critical care setting is utilized in a one lung ventilation. So this is called protective ventilation, and it is used to minimize ventilator-induced lung injury. So while maintaining adequate oxygenation. So this is recommended parameters, ventilatory parameters. So we recommend a low tidal volume ventilation, which is 4 to 6 ml per kilo. Okay, and adjustment of a respiratory rate to maintain patient normal EtCO2 and PaCO2. So PEEP is adjusted from 5 to 10 cm H2O, and also we limit the airway pressure to less than plateau pressure less than 30 cm H2O. And we have to minimize the FL2 to a minimum level to maintain SpO2 of more than 90%. So why is it so? Because high FL2 can cause absorption atelectasis, which will further increase the shunt and worsen oxygenation. High FL2 can also cause oxygen-free radicals and causing oxidative stress and lung injury. Okay, so although we want to maintain EtCO2 near the patient baseline, but permissive hypercapnia has shown to be well tolerated and may be advantageous in a one lung ventilation. It can also potentiate the HPV, so which will further reduce the shunt. Okay. So this study is actually showing comparison between pressure control as well as volume control ventilation. It's a meta-analysis. Okay. So there's no clear evidence whether which mode of ventilation is superior compared to the other. But this meta-analysis is actually showing that in a patient where pressure control ventilation was utilized in one lung ventilation, it results in the lower peak inspiratory pressure as compared to volume control ventilation. Okay, so and the PF ratio, PaO2 over FL2 ratio in the pressure control ventilation is also better compared to volume control ventilation, right? So most of the clinicians now actually advocate the use of pressure control ventilation already. Okay, so this is another study whether um, um, uh, protective ventilation reduce the risk of pulmonary complication after lung cancer surgery. Randomized control trial. So protective ventilation group, they use a tidal volume of about 6 ml per kilo with a PEEP of 5 and FL2 of 0.5 pressure control ventilation. Whereas a patient with conventional ventilation strategy, FL2 of 1.0 was used with a tidal volume of 10 ml per kilo and volume control ventilation. Okay, so this study actually shows that the incidence of pulmonary dysfunction was significantly lower in the protective ventilation compared to conventional ventilation group. Okay, so protective ventilation does result in the better outcome in the patient in terms of a pulmonary complication after lung cancer surgery. So one of the commonest complication or problem that we may encounter in a one lung ventilation, especially in a lateral position, is the hypoxemia. So what is the level that is acceptable level of oxygenation that is acceptable? So most of the author will suggest that 90% of SpO2 is acceptable. That is the lower limit of acceptable level. Okay, so it is common and management stepwise management is actually recommended. So how do we do it? So initial treatment of hypoxemia is to increase the FL2 to 1.0. So at the same time, we have to check the cause of the hypoxemia. So we have to, most importantly, to ensure that the position of our double lumen tube or our device is actually correct. So most of the time, it will require a fiber optic bronchoscope to recheck the position. Then at the same time, we have to ensure that patient hemodynamic is acceptable. BP is actually acceptable because hypotension can actually cause desaturation as well. Okay. Then let's say positioning is okay, BP is okay. Then we can perform recruitment maneuver to the ventilated lung, as well as to apply a CPAP to the non-ventilated lung. Okay. So application of CPAP can actually cause inflation of the lung, so it may actually cause problem to the surgical view. So we have to have a good communication with the surgeon So if all this maneuver is failed to bring up the saturation and patient keep desaturating, okay, then we have to communicate with the surgeon and resume two-lung ventilation if possible. Okay. So one of the final thing that the surgeon can do is actually clamp the pulmonary artery so that there be no blood flow to the non-ventilated lung, and it will effectively reduce the shunt. So if feasible, then like in a patient who is undergoing pneumonectomy, then that can be done. And this is a device that is they can actually provide CPAP to a non-ventilated lung. Okay. All right, now we go to a second device, which is a bronchial blocker. So this bronchial blocker is an alternative to double lumen tube to achieve one lung ventilation. Okay, so bronchial blocker acts by actually it can actually go through a single lumen ETT to actually go to one side of the bronchus that you want to occlude. So thereby preventing a ventilation to that part of the lung and providing single lung ventilation. So bronchial blocker most of the time is being used in the pediatric age group in which they require a single lung ventilation. Okay, so because for double lumen tube it is not so suitable for a patient below the age of 8. So in the pediatric age group in which they are between 2 to 8 year old, bronchial blocker is actually the primary device to provide the one lung ventilation. Okay, bronchial blocker can be placed either intraluminally within a single lumen tube or placed adjacent to the single lumen tube, means outside the single lumen tube. Okay, this is some of the example of a bronchial blocker. This is an endobronchial blocker. So this bronchial blocker comes with a adapter with a 4 lumen. So one lumen is for the bronchial blocker, the other one is for fiber optic bronchoscope, and the top one is for ventilation. So this bronchial blocker can be placed while the patient is still being ventilated. And you can see that at the end of the bronchial blocker, there is a loop of wire which can be attached to a fiber optic to actually facilitate the placement of the bronchial blocker. So bronchial blocker have to be placed with the guidance of a fiber optic bronchoscope. Okay. So at the end, at the tip of the bronchial blocker, there is also an endobronchial cuff that can be used to inflate and effectively provide one lung ventilation. This is another type of a bronchial blocker, univent bronchial blocker, in which the bronchial blocker is being incorporated with a ETT. Okay, so there are two lumen, one lumen for ventilation and the other lumen for the bronchial blocker. So placement of this bronchial blocker will also require guidance from the fiber optic bronchoscope. Okay, right. So so the least commonly used method to provide one lung ventilation will be the use of single lumen tube. So most of the time, this is being used in the emergency scenario. For example, patient in the ED with a pulmonary hemorrhage or bronchial disruption, in which a patient require emergency separation of the lung to protect the healthy lung from a soil lung. Then a single lumen endotracheal tube can be used in the emergency situation whereby there is a absence of a double lumen tube, or there is no bronchoscope and so on. So a single lumen tube can be used actually in the emergency procedure. Okay, but the fiber optic bronchoscope will have to be used as well to actually aid the placement. Okay, this table is showing the advantages and disadvantages of three methods for one lung ventilation. So we can see that double lung tube is the quickest to place because of familiarity actually. So it can be used to provide suction and bronchoscopy to the isolated lung. It can also give CPAP to the operated lung. And we can alternate one lung ventilation to either lung. Means that we can collapse either lung as required during a surgical procedure. Okay. Bronchial blocker, easy size selection, so it's easily used with standard tracheal tube, easier placement in difficult area because a difficult area can actually pose problem for double lumen tube insertion. Okay, so endotracheal tube advanced into bronchus, so easier placement in emergency and difficult area. So there are also list of disadvantages. Okay? Can go through that later. Now let's talk about the anesthetic choice during provision of one lung ventilation. So actually, the decision to use inhalation or IV anesthetic agent should be based on the standard consideration unrelated to one lung ventilation. So you can actually a lot of study done already to see whether there is any difference on the in terms of outcome if we use a water agent or IV anesthetic agent. So most of the study has come out with the conclusion that there is no difference in terms of outcome in terms of oxygenation or pulmonary complication if we use either inhalational or IV anesthetic agent. Okay. Other intraoperative consideration includes IV fluid. We have to avoid the over-giving fluid because it will wet the lung. And then we will have problem with oxygenation and ventilation. Watch out for any cardiac arrhythmia or hypotension either due to bleeding or due to surgical manipulation over the structure causing compression. Okay? So we have to always remember that airway to the collapsed lung should be suctioned prior to reinflation because there will be a mucus plug there. Okay? And careful about positioning in the lateral decubitus position. It can cause injury to the nerve, to the eye, and also can cause rarely cause dislodgement of the tube. Okay? Dislodgement of the outline, then it will be disastrous. Okay? So post-op management, after the conclusion of a surgical procedure, we have to always remember to re-expand the non-ventilated lung. So how do we do it? After suction of the non-ventilated lung, then we can actually provide inflation at the low level of a CPAP, which is about 20 to 30 cmH2O for about 10 seconds. So how do you do it? Initially, we actually clamp the dependent lung first, and we unclamp the non-dependent lung. Then we apply the CPAP and look for the lung expansion directly. Okay. After that, then we can ventilate both lungs. So if there's no contraindication post-op, we have to aim for early extubation. Okay, because prolonged IPPG can actually cause problem. Okay. Okay, we have to ensure adequate analgesia, multimodal, so that patient can breathe well and to reduce atelectasis and problem later on. Okay, the drain, we have to ensure drain is functioning, review the chest X-ray post-op, monitor urine output, drain output, okay, and ensure patient is on chest visual insatiable spirometry and encourage early ambulation post-operatively. Okay. I think this is all from me about one lung ventilation. I hope you guys can actually benefit from my presentation, and I suggest you all to actually download this article, which is free from BJA, and then as well as up to date and ATOTW. Okay, can actually further read on your own regarding one lung ventilation from this article. Okay, any question you can actually ask me directly or what. Okay, thank you.